I'm Dr. Rajiv, consultant nephrologist, Sunshine Hospitals, Paradise, Secunderabad. I'd like to take a few minutes of your time to talk about fluid management in CKD patients and dialysis patients. This is something which is quite bothersome for nephrologists and patients, and it really requires a multidisciplinary, multi-team approach to solve this problem for our patients. One of the biggest problems that our patients have is knowing exactly how much fluid to take. As nephrologists, we often find it difficult to answer this question because we often don't know how much urine our patients are passing and what they are eating and how much salt they are consuming. So knowing this information is the first step towards figuring out how to help your patients. The presence of excess fluid has a lot of consequences for our patients. It makes their hypertension very difficult to control. It can also cause skin problems because edematous legs can often become infected. This is something that we need to deal with. So how do we go about doing this? So the first thing we do is we look at what exactly is their lifestyle. What is the food they are consuming, how much salt they are taking, what medications they are on, how good is their BP control. We take a look at all these parameters, and then we start to develop a plan to help the patient. The first thing the patient has to do is to understand where his problem is coming from. Patients are often in denial when it comes to fluid intake and salt intake. They will often tell you, I eat only this much. I don't know why is it that my legs are becoming swollen or I'm becoming breathless, even though I've taken only this much amount of salt. And the first thing that any patient has to understand is that every drop of water that is there in your body ultimately came either from the food or water you consume. We are not plants. We don't absorb water from the atmosphere. We don't do photosynthesis and all that. So, taking responsibility for your own health is the first and most important step that any patient can do. Once patients understand that, everything is in their control, they can employ strategies to overcome fluid overload. So the first thing would be to cut down on salt intake. And this sounds like a punishment and actually even feels like a punishment for many of our patients. But again, it's not. We don't want our patients to take, any especially low amount of salt. It's actually the quantity of salt that even a healthy person is supposed to take, which is not more than 5.5 grams per day. And to be frank, yes, in the first few days or weeks, it sounds and looks like a punishment and tastes like a punishment. But eventually, our palates adjust. We get used to a kind of a normal salt diet. I would not call it a low salt diet. We are used to using and having an abnormal salt diet. So we just want them to have a normal salt diet. So you're having a normal salt diet now. Over a few weeks, your tongue adjusts. And later, if somebody actually gives you some salty food, you feel it's very, very salty. So life does get better on a low salt diet or a normal salt diet. The other question that patients often want from us or ask is, can I use this healthier salt, which is this pink salt or black salt or this Himalayan salt? The answer is no, because those salts contain substances other than sodium chloride. And your kidneys, if they can't handle sodium chloride, it's highly unlikely that they'll be able to handle, potassium chloride or iron chloride or, God knows what other metals are there in those salts. So the first thing patients need to understand is that those salts are not for kidney patients. If you control salt intake, fluid intake is to a large extent automatically controlled, because the chief driver of thirst in patients is the serum osmolality, and serum osmolality is to a large extent determined by the salt you take. So that's one thing. And then once you've learned to count how much salt is there in your food, avoid processed foods, do all your own cooking, or at least make sure that you're adding salt only after the cooking is completed. 50% of your problem is salt. But this may not be enough for many patients, because once you reach CKD stage 4, or you're getting close to CKD stage 5, no matter what you do, you will find that you are carrying some edema, and this has consequences for your hypertension and blood pressure and all these things. So at some point, you will need medication. There are some medicines that actually can cause swelling of your lower limbs. And the first thing we would look at is to see if you are on any of them. So some of them are calcium channel blockers like amlodipine, which are very good BP drugs. I mean, they are very, very potent BP drugs, but in a few people, they can cause swelling. So we will see if we can, at least I would see if I can take a patient off those drugs and see if they're responding to that. And if they are not responding to that, then especially if the BP is not under control, then it's probably start using a diuretic. So which diuretic to use? So you need, as you go up the stages of CKD, your response to diuretics goes down for various reasons. So you need drugs which are highly potent, and then the rest is a matter of convenience, the dosing schedule you can tolerate and all that. So the most common diuretics I would use would be something like a loop diuretic, either a furosemide or a torsemide. There are a few differences between these two drugs. Furosemide is a shorter. It would probably, I would probably be dosing it at least twice or thrice daily. And it's the potency goes down, or the bioavailability goes down when you use. So if you are using furosemide, and the oral dosing would be at least twice what you were using if you had been on the IV version of it earlier. You don't have that problem with torsemide. So with torsemide, it's a long-acting drug. You can dose it once daily, or you can even dose it twice daily if you want a more better action, or a longer or more powerful action. And with torsemide, one of the advantages is that the oral and IV formulations are almost equivalently bioavailable. So that's one thing. And the other thing would be to kind of use other medications that finally bring your BP under control. There are a whole bunch of medications that you can use. Apart from this, in patients who have difficult to treat hypertension, we need to see whether they are having some treatable cause, something like obstructive sleep apnea or renal artery stenosis. Quite often, if you treat the obstructive sleep apnea, a lot of the hypertension goes away, and you're able to bring down by at least 2 or 3 drugs the number of medications they are on. So that would be one of the strategies that I use in controlling hypertension and fluid overload in CKD patients. In dialysis patients, everything gets amped up a little bit. One of the bigger problems in dialysis patients is they tend to lose their urine output as the years on dialysis progresses. So that's for mortality. That has important consequences for BP control, the number of BP medications you need to be on, and all those things. So one of the strategies we employ in dialysis patients is to try and preserve their urine output and their native kidney GFR for as long as possible. So we would be using drugs like ACE inhibitors, ARBs, and try to limit their ultrafiltration. Try to have a more, instead of putting everybody on 3 times a week dialysis, probably ease them in so that the kidneys don't suffer too much hemodynamic compromise during dialysis. So, and then these patients would require high dose of diuretics, something like torsemide, 40 to 80 milligrams on non-dialysis days. They wouldn't require that on dialysis days for obvious reasons. We are removing their, fluid through dialysis. And the same things which I told for CKD patients would apply equally as well to dialysis patients. So they need to control their salt intake. They need to watch what they're eating, avoid processed foods, add salt only at the end of cooking. And there are some dialytic strategies we can use, like, if the patient's blood pressure is otherwise okay, we can bring down the dialysate sodium so that they don't feel quite as thirsty at the end of dialysis. Obviously, you would do the opposite thing if somebody was having lower blood pressures on dialysis. So BP control and fluid overload control in dialysis patients and CKD patients is a multi-team, multidisciplinary strategy. And it doesn't really work unless the patient really understands what he's going through and what he must do in order to be successful at the goal. And but yes, you can get there if you approach a very common sense approach, and the patient also knows what he wants and is willing to do it. So I hope this was useful and made sense. Thank you.